Welcome everyone to another episode of the PathCheck DICE Global Health Innovators Talk Series. Here we talk about crowdsourced computational health solutions. To know more about PathCheck, please visit pathcheck.org, and to know more about DICE, the epidemiology center using data science, visit dice.pathcheck.org. And if you'd like to join our really energetic research volunteer community, please head out to tiny.cc/PathCheck Slack. And if you're interested to know more about the past talks in the venue, please check out tiny.cc/PCF Research Talks. With that, I'd quickly like to thank all my co-organizers for putting this talk series together: Ramesh Rasker, Nisi Hudson, Graham Dodge, and Nina Resik. And a quick introduction about what the talk series is about. The idea is to bring speakers who are creating an impact in digital health using AI, software, and technology. And the primary motive of this talk series is to drive collaborations in AI for health, which are cross-disciplinary in nature, from computer science, medicine, bioinformatics, social sciences, and much more. And today we have a special guest, and I have our president, Graham Dodge, here to introduce the guest for us. Graham, please.
Thank you, Rohan. Hi, everybody. I'm Graham Dodge, president of PathCheck Foundation, and I'm very excited to introduce Dr. James Wilson, who is the CEO and founder of M2 Medical Intelligence, Inc., who specializes in operational health security intelligence with a focus on the anticipation, detection, and warning of infectious disease crises. He has led the creation of several systems used for the anticipation and detection of infectious disease crises and disasters. Dr. Wilson was the first operations chief of the Department of Homeland Security's National Biosurveillance Integration Center. He also led the private intelligence teams that provide tracking of H5N1 avian influenza as it spread from Asia to Europe and Africa, detection of vaccine-drifted H3N2 influenza in 2007 and 2014, warning of the 2009 H1N1 influenza pandemic, and discovery of the United Nations as a source of the 2010 cholera disaster in Haiti, and last but not least, warning of the 2020 COVID pandemic and several investigations of alleged and confirmed laboratory accidents and biological weapon deployments. Dr. Wilson is a strong advocate for effective and accountable global health security intelligence and the need for credible and balanced threat assessments. So Rohan, if you can end the slide screen sharing, we'll allow Dr. Wilson to sort of introduce himself, and welcome, Jim, if you don't mind me calling you Jim, to tell us about your background in a little bit more detail.
Yeah, I have a weird background, right? I am a pediatrician as well, so I do clinical duty, and I'll hang out with the kids in the clinic and see runny noses and talk to parents and directly on a patient family to patient family basis talk to them about vaccination. And so a lot of the struggles we've seen with COVID playing out, in the media and with the authorities trying to convince people to vaccinate, I've been dealing with that issue at every single level of my multiple career paths here. And yeah, I've done some weird, interesting work. I was recruited when I was a med student to get into the world of Ebola. That's how all this interesting stuff began. And back then, we were trying to use satellite imagery to forecast Ebola outbreaks. And I think those models back then, it was tricky. We couldn't figure out how to validate them, because that was really the beginning of my career path, is that we discovered that there was no operations center for watching the world for this stuff. It's really, the information is captured through human networks and networks of experts, in the public health and biodefense communities. And, and that's not a bad way to go about things. It's just the world is a very big place, and eventually you're going to run into a situation where you didn't really have human people that, human experts who are trusted components of your network on the ground when something's happening. And then you're forced to react to a signal that you don't have a whole lot of validation to go off of. So, yeah, I've been doing this work a long time. And and yeah, COVID was sort of the pinnacle of, it's sort of like you feel like, the universe has put you in a place to do one thing. And for heaven's sake, that was definitely culminated with COVID. And so I used to be a pretty angsty person. I don't think you can't be an angsty person and do warning, for this type of stuff. And after going through COVID, I have this, it's weird. I've got like this weird sense of peace. Like, okay, I've done what I was put here to do. So
That's it.
yeah.
Now you're done.
So, I'm like, okay, now go on a talk circuit. I don't know.
Well, and I've experienced the angstiness firsthand because you and I have known each other for a while. And I'll just sort of add that I met Jim when I was CEO at Sick Weather, and you were at the forecast. What was the name of the forecasting center?
Golly, we ran a couple of iterations of prototype centers. We had a Black Canyon infectious disease forecast station. We had a national level station. We had a world station where we looked at different countries. Yeah, we've played around with this, and I have to say that we're not really. I think the world of forecasting, good heavens, we could talk an entire podcast about what the heck do you mean by forecasting. And in some circles, forecasting is the F word. I mean, like, people really don't, it really triggers them, and to me, I just look at it as a tool to give us anticipatory information so that we know that, okay, we expect to see a rise of disease, right? We are predicting it based on routine baseline data, and we know this is the time of year to see this, and here are the bands, of expectation for high or low disease activity for this time of year, that kind of thing. Very much like climatology, right?
Which is why when we met, we were both working with AccuWeather, and we met up in Vegas to help support both of our mutual integrations into AccuWeather's forecasting system.
Yeah.
And
that was predictive.
Right. So weather and climatology has always been a great metaphor for people in this industry, but it's not exactly a perfect metaphor, as we both know. So speaking of forecasting, and I guess really digging into that signal validation to then be able to make a forecast or a prediction, can you walk us through the timeline of your company, M2 Medical Intelligence, and the identification of COVID-19?
Sure. So our company, for decades, we have done historical case studies on health security crises. And what we do is we go into the historical communication archives. And when I say that, usually what we mean is local media reporting from a major metropolitan area in history that encountered a previously unknown pathogen or novel infectious disease crisis, right? So an example of that would be Philadelphia in 1918, right? And understanding and unpacking one day at a time very carefully, how did that human society recognize that there was this disturbance in the force, to use a Star Wars analogy here. How do people recognize that their daily routine, their daily activities are now being actively disrupted by something different? And I don't care what that something is. It's just they perceive that something has changed. And we've done that over and over and over and over again now over the years, some of which is publicly available, some not. We're probably the only team in the world that's looked at 1889, 1918, 1957, 1968, 1977 with the reintroduction of H1N1 to global circulation. And we very carefully parse out how did people communicate that crisis. And what we found is over the history, there is a reliable sequence or a reliable pattern that I loosely referred to as the exogen sequence. And it's kind of like the DNA of the sociology around this phenomenon. And when you understand these indicators and you learn them and you get dialed into that world, you start to look at the global surveillance patterns in a very different way. And you start learning to parse out, okay, I don't care about these 5,000 other reports of cholera and malaria and dengue. I care about this one report. This one is the one that bugs me. And it bugs me, no pun intended, because, because I know that if this pattern goes this way, we could be dealing with a global crisis, right? And so it's directly analogous to me being in the clinic. I see a child come in, they have a rash, they have a fever, it's this certain time of year, and my brain is already going down that Bayesian network that says, okay, the probabilities are taking me towards this clinical diagnosis, okay? And I think that discipline, we have never codified in a form of a book. We've never discussed it publicly. We have had concerns about the sensitivity of some of the aspects of this discipline. You are monitoring the behavior of officials when you do this work, because that's part of the pattern, right? And what's interesting to me is that over the years, I've noticed that we keep making the same mistakes with warning. It's clear that public health is not queuing off the same indicators that we're queuing off of. It's clear that we're kind of talking past each other. They focus on different types of information than we do. And so there's still some issues of how do we create a sustainable process going forward? How do we create corporate memory? How do we create sustainability? And then Graham, as you and I have discussed, how do we do all that when there's no market signal and nobody seems to really care to support sustained funding in this space? And especially after everything we've been through with COVID and all the politics and all the hysteria and all the, where do we go from here?
Well, since you've already referenced one movie and your background is from Blade Runner, I know you've seen the film Don't Look Up. And I feel like this is a good—
I was traumatized by that film.
Right. So for those of you who are watching and have not seen it, it's about scientists who have that sort of expertise, ground truth sort of expertise in this case, astronomy, and they're seeing a comet coming right towards Earth, and they're trying to get that risk communication out to everyone, all the stakeholders who you would think would be listening, it would be receptive, but that's not always the case. And that's basically what you're describing.
Well, when we provided warning for swine flu, that's exactly what happened. I mean, it played out that way for about 2 weeks, and we were very deferential at that point in my professional history. I was very deferential to our government and to CDC and to my colleagues at CDC who were my friends, and I really wanted to do things the right way and just wait for CDC to catch up. And honestly, after doing this enough times now, I just realized that we live in a world where things are so complex and no one can be allowed to make a mistake. So everybody hesitates and makes sure that our facts are together and everything's fully validated before we say anything publicly. Well, okay. Meanwhile, the virus or whatever is going on, it doesn't care. It's already penetrated the air traffic grid. It's already inside the United States. It's already transmitting by the time we get around to saying something about it. And in some cases, somebody's already dead. And so to me, it's like, well, okay, we need a different way of connecting the communication here. We need a different way of providing warning. And that's why you and I were talking around, our conversations with AccuWeather way back when, is we were trying to find a different way of sharing information, where in the meteorological community, there were commercial entities that basically were just sort of sitting on top of government provided data and then translating that for the masses. And there was still enough market interest to enable that industry to flourish, right? I think the challenge, though, in today's world is, well, okay, now everybody's all about social media. And we know darn well that social media is about sensationalism and hype and hysteria. And we will not participate in hype and hysteria, because for us, there's danger in that. You can blow your supply chain, where you trigger panic buying of critical supplies that we need for our frontline responders, like N95 masks. You can create fear among your responders, where ICU nurses who might be single parents themselves don't want to show up for work. I mean, there are all kinds of ancillary effects here that if you don't communicate properly, you could trigger a lot of negative effects that will impair your response. And there's serious consequences to that. So it requires really careful thought, when you're engaged in this kind of work.
Well, and as we both have experienced, when you are trying to communicate through a meteorological type consumer service about risk, what you end up, the trap you fall into is that in this particular application of this information, there is no room to then back off and say, no, everything's fine now, go about your way. So having that variability in that risk communication, whereas with weather, you can say, oh, it's actually a nice, pleasant day, no chance of rain, you don't have to take your umbrella. It seems like with flu season reporting, for example, once flu season, risk notification starts, it just stays the same until they feel like flu season is over. Yeah. So maybe, can you speak to your feelings on that kind of?
Yeah. So I think one of the things we noticed with AccuWeather is we took a more technical approach, as you recall. We were very here's your prediction for coccidioides, right? That's a mouthful. It's a fungal infection, right? And people, the layperson is like, what the heck is that? And it doesn't, it's too technical, right? So we didn't have it broken down to layperson understanding of here's the so what for you, right? And the thing about weather is it tends to affect everybody, and in some cases it can affect a large group of people acutely, like wildfire risk, right? Or flooding, right? And so it's an easy to understand concept too, that's very translatable for the masses. But when I'm talking about something like, coccidioides, I mean, that's a mouthful, and you have to really unpack, why are you even talking to me about this? And will the audience in their 5 seconds worth of attention span on social media stick around long enough for you to get all of your words out of your mouth? And, and as a technical person who immediately goes into tech speak, that's a hard thing to do, right? And so we were really challenged to try to share these predictions. Now, we did have success with Lyme disease. We had success with flu because these were well-known diseases, right? And for the lay people, they understood what these diseases were right out of the gate, more or less, right? What we found is that the public behavior was interesting, because if the public is used to these diseases, if they are desensitized to the risk, then they still don't really act. They don't really care. I mean, and so then we shifted gears and we jumped into closed physicians' social networks. And we were leveraging and partnering up with companies that were servicing physicians. And we thought this would be the aha moment, because then we could bridge forecasting with a market pulse signal, sort of a preemptive pulse, to reach for diagnostics, right? And what we found is that we could do that, right? So if we gave them a prediction and said, hey, listen, heads up, we're expecting a bad year of Lyme. Then what we saw the physicians do is ask about, okay, well, how do we diagnose Lyme disease? Let's go back and review that, right? And then, and then they say, well, remind me again, what's the test we should order for that if we suspect it? Well, okay, now you've got a connection point in commercially with like LabCorp and Quest, right? And if you look at their market footprints, I mean, that's a pretty big industry, right? Diagnostics, right? And when you're dealing with a disease that is probably 90% underreported in the first place, you're drawing out a signal now because you've triggered diagnostics to go look for that disease, just like with COVID. So a lot of our experience with COVID, we had prior experiences with other diseases giving warning, and watching the testing behavior of physicians and healthcare providers to draw out a signal. Now, here's the thing. You go drawing out that signal, guess what happens next? They say, oh, look, your prediction was accurate. Now, look at all this disease I'm finding. And then we sit back and say, okay, now ethically, let's not play games here, folks. Did we really forecast this? Or did we enhance the signal because we told them to go and look for an underreported disease, right? And so there is an ethical thing that you need to be aware of when you engage in this work, and a bit of truthfulness that you need to share with people. Because if you don't, and somebody else comes in from the outside and points this out, like a journalist or whatever, then people are going to lose trust in you. And as you have seen readily with COVID, if you don't maintain trust with your audience, you are in big trouble, right? Now, what did the physicians do next? Well, they were thankful. They thought that was interesting. Then we tried that with flu, okay? And we actually fed them anticipatory intelligence on the vaccine-drifted 2014 season, right? So we were picking up on preemptive indicators that we were going to have a potentially bad season of flu, right? What we noticed right away was that these docs, most of them were on board and thankful for the information, the heads up, but a good chunk of these docs started expressing anti-vaccination sentiment. So this, and we're talking, if you do the math, right? So this is years before COVID, we started unpacking pretty strong indication that a significant portion of our healthcare provider community were anti-vaccination for flu. Right. So it's really interesting when you engage in prediction and forecasting and communicating that information, you'll notice that we're not obsessed with the algorithms, right? We're not mathematicians. We're more obsessed with, so what? If I give you this information, what is the ripple effect of that process, right? And what was really interesting is that we got into fights with people. We eventually left the platform because I just couldn't stand to see my own colleagues behaving this way. I mean, it was awful. It was horrific what some of these people were saying. And it was clear that they were not keeping up with the peer-reviewed literature. It was clear they did not understand what vaccines were and what they weren't. And a lot of the debates about COVID vaccine, about what value that vaccination does for the patient, we saw those same debates occurring with flu leading up into COVID. So it was a lot of preemptive, predictive, and anticipatory intel, if you will, that helped us anticipate what we would later see with COVID. So I share all this with you because I think when you read about disease forecasting, on CNN or whatever, the layperson is led to believe, oh, well, this is just, we can predict the future and everything is hunky-dory and we'll see things coming. And it's a lot, there's a lot of nuance and the waters can get very muddy. And it comes down to, okay, if I don't tell you what's about to happen, now let's see if my forecast validates. Because if I say something, I'm influencing the entire process of human diagnosis, of human perception of that risk, right? And so really what we're engaged in is this weird game of predicting human perception of disease, sometimes not necessarily the disease activity itself. So you need to kind of keep the two separate. Does that make sense?
Yeah, well, and it goes to show how much the context matters and sort of the ground truth experience that someone like you has to be able to first even say, hey, that report looks really bothersome to me.
Yeah.
Let's dig into that further. So to go back to the timeline of COVID, because I want to highlight the fact that your organization was one of the first that actually started sharing some intel with your clients, and not asking to share what that intel was, but
I can share it. It's not.
How early were you guys basically talking to your clientele and saying, hey, this is going to be a problem? Because I've seen your LinkedIn activity as early as like early January, maybe late December. I don't remember off the top of my head, but can you speak to that?
Yeah. So it actually was a media report. So it's the butterfly effect. Right? All of these events, it's the butterfly effect. We can always go back and find one media report or one email from a human source that we trust that sparks this massive, complex, networked pattern of indicators and engagement and human, just human strife, right? I mean, just all the morbidity, mortality, socioeconomic disruption, et cetera. It's amazing. When you go back, it's one point, one report, one person that sparks it all, right? over and over and over again. So for us, it was reporting of unusual respiratory disease in Wuhan. The article was in English. We have monitored China for decades. So we know darn well that if it shows up in English, it probably is on the ground for at least a month, because there's delays in translation. Sometimes there's censorship issues with the government. I mean, all this goes with the territory of China, right? We do not pay attention to certain syndromes as much as we do others. Anything that says it's a respiratory disease and we don't know what it is, and it's generating unusual impact in a hospital, that is a priority one alert until proven otherwise. And we will engage, track, and monitor that situation until it threads out. And threads out means the signal just fizzles out. Now, sometimes it fizzles out because it wasn't a big deal after all, right? It was maybe just a one-shot spot in that hospital and it was over and done with, and nobody really knows what happened and nobody diagnosed it and they didn't have assets to do so. Okay, fine, that happens, right? And it happens a lot, actually. But if it spreads and persists despite the presence of censorship, that, get ready, buckle up, right? And you want to buckle up, but don't panic, right? Because panic is not helpful. We potentially are about to go to battle here, and panic doesn't help, right? A little bit of anxiety, not bad, right? Because you want to pay attention to what's going on. But this is where you need to start thinking about, okay, I see the indicator pattern. I know what this could be. But if you jump it and go right to pandemic, then people are going to blow you off right off the bat, right? And I think, for me, I just sort of approached this. I've done it a couple different ways every time, trying to figure out how's the right way for me to tip people off that our team is paying attention. And if our team is paying attention, you better be paying attention, right? But not go right to 1918, And I do think that most people, not most people. I should be. Well, the audience can tell that I get it triggers me when people get hysterical about this type of stuff, because you have to be so careful with how you communicate. But right. on the 30th of December, 2019, we saw that article, right? Then the 31st, we're jumping onto LinkedIn. We're issuing a post on LinkedIn, and we went through the extra effort of pointing out, oh, by the way, San Francisco is connected to Wuhan by direct nonstop air traffic to the tune of over 5,000 passengers a month, by the way. And if this is something that is going to be something, right, just FYI, it might already be in San Francisco. Just heads up, right, that we're tracking this. We don't know what it is. It could be total misinformation, but we're threading this out. Then on January 1st, we jumped over to Facebook and notified the Global Outbreak Alert Response Network publicly that we were on deck. The last time that I communicated with WHO directly was swine flu. So that was interesting. And I know the principals at Gorn. They may never acknowledge they know me, but it doesn't matter. I don't care. So you'll notice a pattern of lead follower, get out of the way. We did not wait for permission. We did not wait for people to give us their blessing this time. That was a lesson learned from swine flu. Swine flu, we waited and waited and waited. We simply got lucky with swine flu. I mean, we just got stupid lucky there that pathogen wasn't something that was really going to be a problem, right? And we've had enough of these torpedoes across the bow historically in the US, where we just got lucky over and over again. And it kind of gave us all a false sense of security and a false sense of, well, these aren't things to worry about kind of thing, right? I was around during SARS, right? So the other thing that was running through my head is if this is like SARS, it could be extremely disruptive and scary and have a high case fatality rate, but it also could fizzle out. It may not propagate to a full global pandemic, right? Now, let me pause for a moment and point out that word pandemic. If you ask 10 different people in our mutual communities to define that word, you will find many different answers to that question. And I hate that word because it's so easily abused, in the media, right? So you may recall that we referred to Zika as a pandemic. Where are we now with Zika, right? So I'm not trying to be dismissive of the risk, right? And it's devastating to the patients and families involved with these pathogens, right? I mean, horrible, right? But we need terminology that gives us a bit of precision here so that when we communicate, here's what we're tracking, you understand, okay, this is the measure of response I kind of need to start thinking about, right? Versus go straight to 100 in terms of anxiety and panic. And then that's counterproductive, right? What we need is to pull people back down into a balanced conversation so we can rationally discuss options for what we do next, right? Mm-hmm. So January 1st, we told WHO, we were already pulsing LinkedIn. We were sharing insights on social media. Part of that is an operations process because we gather sources of information that way that we might not have had access to otherwise. So people come to us and share information with us because they see us as sort of a gravity well of insight, right? We also triggered several journalists to go look at the problem. And that's another standard operating procedure. We did that in Haiti as well. And then on January 5th, that's when I picked up the phone and called our emergency manager that we work with our hospitals. And he's a guy that I had a trusted relationship with for many years. And that's a key lesson learned, by the way, is you've got to have trust relationships on the front end of this stuff. You can't go scrambling to build trust afterwards. You've got to have these relationships up front, because then I can come to him and say, hey, here's what I know, here's what I don't know, and here's why you need to care. Acknowledging that there's a lot of squishiness in the probabilities here. I mean, so we were communicating on January 5th, and I was encouraging him to start thinking about preparedness, start thinking about checking a travel history in the emergency departments. I'm thinking of Toronto. I'm thinking of SARS, right? I'm thinking all it takes is one unrecognized patient to penetrate a major metropolitan hospital, say a trauma center, cause a stream of exposures inside that center, potentially all the way up into the ICU. If the ICU gets compromised, that entire hospital goes offline. You are dead meat, right? As a city and potentially as a region, right? And if it's a trauma center,
what of this, the so what that we've talked about in the past as well. So the ICUs, the beds availability.
Yeah, so we understand well the emergency department ICU access of the hospital. That is the core of that facility. If that core gets compromised, you are in deep trouble. And the problem is we are talking about doing these actions before public health is even engaged, because that kind of risk moves it's already moved. It's already potentially inside the country. And we don't have diagnostics yet. We don't even have a full clinical description yet, right? We don't have countermeasures that are specific to the agent yet. What we've got is universal precautions. What we've got is enhanced infection control. Thank God, right? At least we had that, right? And so, these are the things we're talking about. Meanwhile, who's mapped out the critical medical supply chain? Do we have any idea what our N95 mask supply is going to look like here over the next couple of weeks? Well, those are some really ugly questions that we still don't have answers to. Like it was a miracle that we navigated through this, quite frankly.
Well, but unfortunately, I think at the cost of causing more confusion with the general public by saying, don't go buy masks. They didn't want like a run on the mask market so that the hospitals didn't have them. And so the first messaging, as I recall, was don't buy masks.
Yeah.
And then it turned to you must wear a mask.
Well, yeah. And so there were a lot of people commenting in the media and on social media and just mouthing off about the mask situation without understanding what was going on behind the scenes with the supply chains and the criticality of prioritizing access to our responders. Okay. I mean, and this is where it drove me nuts to see just some random academic coming in and say, well, we're doing it wrong because, Trump's a bad man. It's like, you know what? I too may disagree with how Trump did things, but we don't have time to play politics right now. You know, we need to come together to fight a threat that doesn't care who's president, doesn't care what political party's in power. I mean, yes, we have injustice in this world. We don't have time for that right now. We have time for the virus right now, right? And that's where I would take issue, is we needed a Winston Churchill here. And we didn't have that. What we had was this cacophony of noise without context, without any thought before somebody opened their mouth publicly, right? And certainly they could come back and criticize me of the same, right? So I'll throw myself under that bus too. But fast forward, right? So January 5th was the beginning of a daily conversation by phone with the emergency manager. And this emergency manager had some unique skill sets that I think we just got lucky too, is that he had had experience as a humanitarian responder overseas. He had experience putting together large scale operations. He was on deck for the Vegas mass shooting, which is one of the biggest, hospital emergencies that our country has seen. He's had experience with wildfires and floods. And I mean, this guy just has a wealth of experience. And so I was blessed. I mean, this was a career highlight. I had somebody who listened and knew what to do next, and wasn't afraid to act, right? And wasn't afraid to take a chance, and maybe even a little overreact a little bit, just in the spirit of protecting the infrastructure, right? And so it was incredible. So from January to February, what we were doing then is really assessing what is going on in China, right? We knew darn well that the Chinese would probably, they'd tell you one thing, maybe they won't, there's censor, we knew that. But we were watching for a cascade of indicators. We had already checked the box on the initial indicator set. Now we're looking for, okay, what's the next thing we need to look for? We need to look for healthcare worker in illness. Okay, well, actually, technically, first, we need to look for fatalities. So we were technically already talking and already engaged before there were even any fatalities reported, right? So we're looking for fatalities. We're trying to work up gross estimates of, okay, what's the fatality rate based on what they're seeing, knowing darn well we don't really know the denominator, right? We also were looking at, okay, are the healthcare workers themselves getting infected? Because if they're getting infected and hospitalized themselves, that's a whole nother step function of concern, because healthcare workers are exposed to a lot of baseline disease every day. And they are an important canary in the coal mine. If you see healthcare workers going down for anything, that's a priority alert for us, right? And so that's another one of those example critical indicators that we seemingly keep missing. And we see that with Ebola, we see it with Nipah, we see it with other diseases that are high threat agents, where you see clusters of healthcare workers unusually getting sick to that degree. You better drop everything and figure out what's going on. And you better start talking with your leadership, your nation, as to whether or not we ought to think about restricting the air traffic or monitoring air traffic or something, right? So anyway, so we were walking through that, and you saw us doing that on LinkedIn. We were very carefully, and we were doing that publicly because, again, we would have people say, hey, I read what you're looking for, and look at this piece of information. So we crowdsourced a lot of information that turned out to be pretty credible.
Well,
So,
I'll just want to interject real quick that at this moment in time, during the pandemic, back in, it was January, February 2020, after, end of December, you were recognizing these early signals and reports in the news from China. At this point in time, by the time you start posting on LinkedIn, you were my rock during the chaos of this pandemic. I was always checking LinkedIn. I know LinkedIn tells you who's looking at your page. You probably saw that I was looking at your page all the time, because I couldn't.
Actually, no.
I didn't trust what I was seeing necessarily, because I knew what the hyperbole machine was in the media. And so having somebody with that, again, sort of ground truth experience that you had was very important to me. So I just want to put it out there, anyone who's watching, be sure you follow Dr. Wilson on LinkedIn if you want to get some of the really, objective analysis that we're talking about. So I'll let you go back to continuing with the timeline. I just want to make sure.
Well, I really appreciate that, Graham, because I mean, like, we don't really get thanks. I think a lot of us have just sort of decided that, well, we're going to do our bit in this world, but we're going to disappear, and nobody's ever going to know really what we ever did over these decades. I mean, like, we're an unrecognized group. There's no military outfit. We don't get medals. We don't get recognition. Nobody thanks us. We lost a $10 million company because of swine flu. You know, we couldn't get a market signal. Like there's no thanks in doing this. You have to really love what you do passionately to do this. My wife will tell you this. I mean, she thinks I'm crazy. I don't know why she's still married to me, but really. And if you ask a lot of public health people to be utterly fair to them, they'll probably say the same thing, especially all these folks, these poor people who've left the profession after all the abuse that they've sustained. I mean, so we're all in this together, okay, on that front. But let's talk real quick about where the wheels came off the bus. So I would argue that we were trying to keep it cool through January and trying to reassure people. And what we were doing, and we were criticized for that. A lot of people have told us, you are blowing this off. You are empowering misinformation, right? You're empowering the extreme right wingers, whatever the claim was, right? That you're doing a bad thing by being apparently dismissive. And I had to keep saying, the fact that we are even bothering to communicate about this should tell you that we are working 24/7 on this issue. I have had minimal sleep for weeks and months on end, right? We're not getting paid anywhere near what we're putting time into on this. We are killing ourselves to engage this issue, right? We do treat this seriously, but we will not take these scenarios out to the apocalyptic end zone. We're not going to engage in that pattern of communication. It's inappropriate, it's unprofessional, and quite frankly, it hurts our security of our nation and the world, okay? We need to come together. We need to come together in a calm, measured way, right? Like we need to, this isn't gonna go away, but let's talk about measured response, right? So it's a lot like hurricane warning and hurricane graded response. You don't evacuate a city if you see a tropical depression. You alert people, you tell them to get ready, right, in case it escalates, right? But you're not evacuating the city. If you're tracking a Cat 4 hurricane out in the Gulf and it's coming into New Orleans, you're prepping people to go, right? So, I mean, that's what I'm getting at, is how do we do that kind of process, right? Well, we were doing okay. Then February, I think things dramatically escalated in terms of just the social media amplification of hype. Like, we were having pretty balanced conversations, I thought, through January. I thought things were pretty measured and well considered, and we were in total agreement with WHO. We thought everybody was doing a pretty darn good job of keeping their cool. Then we had validation of what the Chinese were seeing when the agent showed up in Hong Kong and Singapore. That was a major, watershed moment, right? Is we needed to see how the folks in Hong Kong and Singapore managed the crisis. And what you'll notice in that first wave, they did see a pretty impressive surge of hospitalizations, okay? What you didn't see was a overwhelming surge of ICU admissions and an overwhelming, mass mortality event. It looked like on the surface that yes, it was a crisis. Yes, it was a priority emergency. No, it was not an apocalypse. And we're talking about extremely pop-dense areas here, right? These are metropolitan areas of the world, right? Heavily connected in the air traffic grid. Then we watched what looked like an undetected incursion into the ICU network in the Netherlands. That got our attention because we were thinking Toronto, right? Like, oh my God, here we go, right? And that didn't look like a whole lot. And then we watched the Bavaria outbreak, right? And clearly the virus had gotten into Germany, and it seemed to be pretty ho-hum. They put people in the hospital as mainly for observation, and it didn't spread like a gasoline fire. We also noticed that it wasn't spreading like a gasoline fire, this overwhelming pulse of unbelievable, overwhelming hospital demand like we saw in 1918. We did not see that in China. We did not see that in Southeast Asia. And this was perplexing. So either we're dealing with a seeding event where the virus is just sort of, it hasn't quite gotten going yet, or the virus isn't adapted to the human host yet, right? So it's not transmitting as efficiently as it could, or all the above, or we're just dead wrong, right? And we just don't know how to analyze things, right? I mean, all those were options on the table, right? Well, now we're into late February. Now I'm really fighting with people. I felt like I was fighting with everybody. I'm now disconnecting all types of people off my Facebook. I mean, I stopped posting on Facebook. That became too hazardous, quite frankly. We received threats. I had people asking about my daughters. I mean, like it got ugly, right? And I noticed on LinkedIn that I was disconnecting people I have known for decades, and greatly respected professionals who otherwise, in every other situation, every other crisis, we worked together. They were awesome. They were people I looked up to. Some of them were my mentors, and I had to disconnect them because of the psychological strain of this event. And that's really the elephant in the room here is, what does this do to people's mental health? When you have unbridled uncertainty and hysteria spreading, this is not helpful, right? And this is precisely the thing that we were hoping to avoid, but we just watched it spread out of control and nobody seemed to care to rein it in. So late February, we're talking about February 25th or so, thereabouts. That's when we noticed that the situation in northern Italy now was looking unusual. Like we saw reassurance in Japan, reassurance in Singapore, reassurance in South Korea. Like by that point, we had multiple countries where it's like, okay, this looks pretty poopy, but manageable, right? Like not overwhelming, crash your stock market, like we might get through this, and we were feeling hopeful, right? Like, yeah, this is a little bit more interesting than SARS was, but still hopeful, okay? And then we saw northern Italy, and they blew their medical infrastructure. Like it was ugly there. And if you look at their statistics, now you're looking 1918-ish, right? I mean, it was impressive. And then at that point, we escalated the conversation, we escalated our advice, and that's when we told, our folks, it's time to move. We've kept it together up to this point. We've prepared you, but it's time to move. And we need to activate now a hospital surveillance system that is informed by the warning intelligence that we've gathered around the world. These are the data elements that we must track if we are to understand what's about to happen and the impact to our infrastructure. So the warning intelligence informed our hospital surveillance system. We stood up the hospital surveillance system in 10 days. We had every hospital in our state reporting to us every 24 hours. That was thanks again to the partnership we had with this gentleman. Outstanding, right? Just absolute career record-breaking stuff. Just a lot of luck, a lot of happiness to that, right? By the time we got the system up, and this was a month before the feds, by the way, and by the time we had the system up and running, we noticed that we were already in the first wave. Talk about reactionary surveillance. I mean, I've used that term many times, that this is a classic health security crisis indicator, is to see people building surveillance systems after that you're already in the middle of it, right? Well, here we go. And so our primary concern, our engagement point is in that golden hour before first contact with a previously unknown pathogen, because that's the most dangerous time of engagement because of lack of familiarity among everyone, including us, right? So that is the point of greatest anxiety, greatest stress, is because of that uncertainty. Once we got through the first wave, the second wave, even if we saw more hospitalizations, which we did, by the second wave, we'd already been through it once before. We'd already gone through the hell of just sort of accepting that we're now in an emergency that we've never seen before in our lifetimes. Okay, now we know what to do, right? We still may have unanswered questions, but generally we know what to do now. And so we saw that the stress level and anxiety with each wave fell over time. And we had seen that with Ebola. And it was kind of interesting to sort of live it, right? So we would watch it with Ebola from afar, and then we actually went through it with COVID here. So the theme that you want to hear through this entire process is resolution of uncertainty is an anchor. You need to do that. So the moment that you detect this bubble of risk that is associated with uncertainty, you must move to intercept that uncertainty as quickly as you can. Because then you're attempting to mitigate fear among your responders and maintain that infrastructure. So no matter what's happening in social media, news media, Facebook, LinkedIn, no matter what, at least your hospital is still got its doors open, still digesting patients and processing them. And your nurses are still showing up for work. Your docs are still showing up for work. You know what I mean? So that's your anchor for this kind of a crisis.
So since we have about 10 minutes left, I want to touch on, you mentioned 1918, you've mentioned Ebola outbreaks. Why hasn't the past informed and helped us be prepared for COVID-19? And what can we do now to keep surveillance structure in place ahead of the next disease outbreak? And, and on that topic, what then worries you about, the next one?
Oh boy. That's a nugget right there. I am not seeing a market signal still. We do not have a COVID commission. We do not have political will. We don't have sustainable will that transcends presidential administrations, right? So with the swapping out of a president, entire programs will come and go, right? And the corporate memory that goes with it. I've lived through that several times now. I no longer trust political leadership because of that, because we need a sustainable construct. We have approached, I'll be straight up with you, we approached the most famous foundations in the world that claim to be supporting these kinds of efforts, public health wise. They do have a tendency to sustain things a little bit longer funding wise, but we still don't see them interested in warning operations, right? When we provided warning for swine flu, we were sitting in Seattle. And so read between the lines as to why that company failed, right? There's a lot of interesting nuance here. And I think the general lay public really should sit back and ask themselves, why do we not have a National Weather Service for infectious disease? Why do we not have a watch cell? Why do we not have transparent review of warning processes so that we can review what worked, what didn't work, capture the lessons learned, train the next generation of analysts, keep moving so that you have this institutional memory. We do not have that. And I haven't seen that at WHO either. And so these are questions that I think we need to really confront. And maybe now is not the right time to do it because we're still emotionally invested in COVID and everything is still so politicized. But we need someone like Mr. Spock to come into the room. I'll just use the sci-fi analogy again. We need a non-emotional, dispassionate review of what worked, what didn't work, what do we know, what we still don't know, and move forward with that knowledge, if not for our children and our grandkids, right? As far as danger for the future, I do not see social media, the social media industry. They have not given us clear indication yet that they have listened. I mean, if you look at the election interferences, if you look at all the other stuff that's happened with social media, I think we've still got serious problems, right? And how we communicate and who is given the microphone and who isn't. I think these are worthy debates to have as a society, going forward. And how do we engender trust with the public? I mean, in our patients. That's still another elephant in the room. And until we start unpacking these key issues, I think we're going to keep spinning our wheels, and all of our mutual efforts will continue to look like sort of academic hobby shops. And I throw myself utterly in that same box. Okay, so please don't take offense to that. I think that a lot of awesome work is being done, right, in this world, academically, commercially, et cetera. Heartbreaking when a lot of these efforts just disappear. But we need to kind of step back, look at the big picture and say, why are we not sustaining effort? Why can't we sustain effort? And when we can answer that question, then we're going to make progress, I think.
Well, and it seems too that the public needs to ask for it, right? They need to
Yeah.
sort of end it themselves. So do the public health agencies. That's the other sort of part of that.
Yeah.
Problem of continuity, because there are so many siloed, fragmented efforts going in different directions. I mean, you mentioned there's no forecasting center, but I could probably rattle off about 12 that are, being stood up presently or, in response to COVID. But just to make the point that not everyone's rowing in the same direction, unfortunately. And
Yeah. I think let me be clear. When I say a National Weather Service, I'm talking about the warning function, right? So there are two different, with forecasting, you're using a known baseline of data, right? Typically, you've got enough data to drive a forecast algorithm. Warning intelligence, however, doesn't typically do that. It's a different process, right? So different tools to give you anticipatory information. But you're right. But yeah, they're not rowing together. The modeling teams typically don't talk to each other, right? It's sort of everybody's functioning in their little cells, and then they coordinate at the government level. And so, again, it's just sort of like, I think it goes back to what you're saying is the public needs to demand it. If the public doesn't demand it, you're not going to have political will. If you don't have political will, then you're not going to have funding, and then, et cetera, et cetera, et cetera, right? So.
well, if anyone has any questions before we wrap up, please put them in the Q&A. I do see there's some active chats of people commenting and talking, which is great. I guess, as we're kind of, in the final few minutes here, what about the role of just fatigue in terms of this sort of post-pandemic memory loss that seems to be a cycle with pandemics and outbreaks? Is that just something that we can't, in your opinion, is that something we can't overcome in terms of just that fatigue and wanting to go back to business as usual?
Well, yeah, it's a baffling thing, right? And we keep reliving the same lessons that we should have learned, in terms of warning and response. I would say that, at least we've called that out now, right? Very loudly. I think most lay people know that now, right? And I don't think that the public knew that before. So that's good. Trying to pick the positives out of this here. The cycle. So I jokingly say that we live and die with every crisis. So we're about to Phoenix yet again. So our team's actually about to disappear. And it's because we may be coming to a point where we're accepting a new baseline of disease known as COVID. And it's no longer a emergency crisis, right? It's not to dismiss it. It's not to say that it's not deadly. It's not to say that you shouldn't get vaccinated. It's just that we're just accepting the status quo, right? As far as the boom bust cycle, some of the lessons that we do glean during these crises are applicable to daily medicine. The evolution of point of care testing for flu. We used to only test patients who were hospitalized for flu with the hospital lab involved, right? Now I can just pull out a kit and swab some kid's nose and I can tell if they've got flu A or flu B in 5 minutes, and that's amazing, right? On the other hand, that's completely changed our understanding of the disease baselines, of course, through public health surveillance, right? But, I think the fatigue thing is interesting, and I don't have a good answer for that. You go through cycles of capturing lessons learned during the downtimes, and writing your academic papers and hope that somebody's bothering to read your papers, that kind of thing. As an operator, that frustrates me because, it feels like, we're always dealing with a new cast of characters in the leadership with each crisis, new cast of proclaimed experts, and yet no sort of common thread of corporate memory. So we need an institute. I don't know how we get there.
Well, and you mentioned testing, in terms of the prevalence of at-home testing, like that does seem like a modern innovation that could help us be more prepared for the next pandemic. If we keep the home fires burning, so to speak, of these lessons learned through continuous testing, not exhaustive testing, but within reason, so that these tests are available to people, and they know that, okay, I'm experiencing these symptoms, I should probably go get one of these tests. And then these devices, the fact that we've got these smartphones that enable sort of a network of human sensors. And I've always been a big proponent of crowdsourcing and wisdom of the crowd in terms of engaging with public health. I mean, between those two things, testing and engagement, maybe that is sort of the combo for keeping the public informed and making them engaged, and so that they are demanding, the systems that we're talking about.
Yeah, I do think that, okay, so as we winnow into, what's a potential thing you could do going forward here, is we do have now mandatory reporting of hospital surveillance. So we now take it for granted that you're hearing about COVID positive. We have 14 patients in the ICU today in our local hospital, right? That kind of thing. That data is now, HHS requires reporting of that from our hospitals, right? So the payer has demanded that. We have noticed with other health security crises, the moment that the payer mandates that reporting element, you stop seeing people playing games with reporting data. You stop seeing the fighting. And I saw this firsthand with the antimicrobial resistance crisis. We had all kinds of challenges with that one. But the moment that CMS came in and said, nope, you must have stewardship, you must report your data to CDC, you will not hide this information anymore, you must have a structured system. I mean, once it's mandated, a lot of the politics around that, disappear. And so you now have a system in place, HHS Protect, and that data, we can always debate the data quality, but I'm a fan of, I'm an optimist in hoping that, well, okay, the first step was done. The hardest part was done, is getting people to report. We'll come back later now and fuss over, can we get the data to be better, like admitted with COVID versus for COVID? I mean, those kind of questions, those are important questions to answer, right? So we can be more accurate with our risk assessments, basically. And so that's a nice foundational element. The layperson, I would argue now, and I'm thinking psychosocially here, they understand now when they read a media report that says the hospital is overwhelmed with COVID, please, for heaven's sakes, go get your vaccination. We are seeing waves of vaccination that coincide with that kind of reporting, right? And we know that is a very old sociological pattern that was noted in the academic literature 100 years ago, is that people, they respond to relevance of threat, right? That, grandma has heard that something in her community is affecting her neighbors. She's going to start thinking about taking action. Like, this is no longer an esoteric hypothesis that was presented on a national news channel. She now thinks that this is something that she needs to act on. She needs to learn more about and act on, right? And so, to me, the anchor point for going forward and engaging the public, in contrast to what we were doing before, is really the infrastructure status. So if your hospitals are humming along but then the other side of that is, if the hospitals are humming along just fine, then people could still sit back and say, well, I'm not going to get vaccinated because there's no threat here. And then the public health guys are going to get frustrated, understandably. And we as healthcare providers are going to get frustrated, understandably, because, let's not wait for there to be a crisis, right? Let's get ahead of this darn thing. But to me, that's sort of your measure. That's your foundational measure for going forward and engaging the public, is what is the status of your hospital? And if you're red alert, that's like your category 5 hurricane. You need to notify the public, and we need to be used to this going forward, right? That you're going to periodically get alerts on your phone saying, hey, you're in a red alert status right now for your region, and it's because of flu, or it's because of RSV with pediatrics, right? So before all this, RSV was a leading cause of filling up PICU beds with kids on ventilators, right? And so these are routine diseases, and we kind of blow them off because, oh, they're always there. Well, yeah, but mamas who need to be aware that RSV transmits in daycares, right? And it's really hard to avoid that. So you need to have awareness. This is what RSV is. This is what a kid looks like when they get in trouble clinically. So there's a whole lot of opportunity here to start blending in preventive education and sort of rolling people up to be proactive in their resilience, So I think that that's your future right there. You and I have talked before about offering training for recognition of emerging health security crises. I think that's a little more nebulous because of the nature of health security crises. They come and go about every 5-10 years, and it's hard to predict where in the world, what's the next one going to be? Is it going to be another Ebola? Is it going to be another Nipah? That kind of thing. So that one's a little bit harder to define, I think. I think for our perspective, we are deliberately waiting a year or two before we offer any training product from our team because we think that the fatigue is significant enough that we're just going to waste our time. Nobody's going to care. We will stand corrected if anybody else disagrees with us, but we're happy to train people. We do believe that it's better to teach people how to fish than to fish for them. Okay, because they understand their own vulnerabilities better than anyone. And that's the other side of the analytic equation is what's your vulnerability?
Well, and your willingness to even talk about that kind of knowledge transfer, I think is an example that everyone should be following. And at PathCheck, we have, we formed as an organization prior to my involvement as an open source collaborative effort, people working together to try to solve a problem. Hopefully that's the other element here to preventing the next sort of disease X pandemic, so to speak. I'm using the word prevention sort of loosely.
I was going to get you for that, but you headed me off at the pass. You knew that was my trigger.
Yes, exactly.
Graham knows me well.
We are past the hour. Dr. Wilson, thank you very much for spending this time with us. Maybe we'll have to do a part 2 because I think we barely touched on a lot of the things I had on my little sheet here. So.
Yeah, I looked at this. I was like, oh my gosh, we could talk for weeks about this.
We didn't even talk about Sweden.
Oh, geez. Yeah.
I won't get you started. All right. Thank you everyone for joining us. Like I said, we will maybe think about trying to get Dr. Wilson back for part 2, but keep in touch with us on YouTube and on our social media to make sure that you're following all these great global health innovator speaker series that Rohan here at PathCheck coordinates for us. Thank you, Dr. Wilson. Thank you, Rohan, and have a good day.
Nice to meet you all.
Take care.
Take care.